Could you tell me more about the new test that helps determine whether a woman needs chemotherapy?
I think she was on
Are you referring to the oncotype?
Yes.
Okay.
Sure. I can start. Yeah. I mentioned briefly that we have about 25,000 genes in each one of our cells with the nucleus. So there are a variety of gene profiles that have been developed and continue being developed to try to test for some of those genes to see if that can help us predict that the cancer is aggressive or not aggressive, or that the cancer will respond to some therapy versus another, including chemotherapy. In the United States, there are several of those gene profiles approved, but the one that is used most commonly is called the Oncotype DX. So that particular gene panel tests 16 of the genes in the tumor and 5 reference genes. So you can think about this. We have 25,000 genes. The test tests for 16. But I think it was the first genomic test that was developed that looks at multiple genes in one test to try to predict outcome. So it's very helpful in some patients, and there is another ongoing trial called the TAILOR-X trial that is looking at this in a prospective manner. So patients are enrolled, we take the tumor, do the Oncotype DX test, and they're being followed over the years, some getting chemotherapy, some getting chemotherapy with hormones, and that will really help us place this test in a more concrete perspective. So it can be helpful for many patients, not helpful for all, and more work is ongoing.
Can I make a comment about that?
Please.
I think that your question really highlights a very concrete example of personalized medicine. So for example, when somebody developed breast cancer that was fed by estrogen receptor positive, we know that part of their therapy is going to be to block or to starve the estrogen. But the question always, or in many women, was should we add chemotherapy? And we used to just try to make that decision by looking at the tumor under the microscope. How did it actually physically appear? And now what we're talking about is that you can look inside that tumor, you can look at these 16 particular genes that Dr. Perez was looking at to see if they're high or low, turned on or off, and that will give you a sense of how somebody would do if you just treated them with the hormonal blockade versus if you added chemotherapy. And that's really becoming more personalized and looking at the tumor in a better way than just sort of physically how it looks under the microscope. So that's where we're going.
This also highlights, see what happens when you ask a good question, you know, you get everybody wants to jump in on it. It also highlights a very important terminological difference in terms of the way we look at things, which is prediction and prognostication, and I'd like to ask Cliff to talk about that.
Many times, and it makes for really good television drama, patients sit in front of the doctor and they say, what are my odds, doc, right? So that's the prognosis question. What's the chance that I will do well or do poorly? What's the chance that something will happen? In the first iteration, this genomic test that you just asked about, the Oncotype, was developed as a prognostic test. So in a group of women, all of whom had similar cancers, their lymph nodes were not involved, they had the estrogen receptor, and they were given tamoxifen, the result of this test was prognostic. A high score meant that the tumor was more likely to recur, and a low score meant that it wasn't. And as a clinician, with my colleagues, we kind of greeted this with more of a yawn than you might think, because simply stratifying somebody's risk as 12% or 8% or 16% in ranges like that doesn't help very much. What we need desperately is a different tool, which is a predictive tool. You've heard about HER2 and estrogen receptor. Each of those tests, while they are prognostic, even more important is that they are predictive. ER, estrogen receptor, predicts sensitivity to the hormone blocking drugs. HER2, while it's a poor prognostic sign, predicts sensitivity to trastuzumab or Herceptin, the drug you're used to hearing about. But we never have had a good predictive test for the benefits of chemo. So a second look at the key data that Edith was just describing was to look at it in reference to the chemotherapy benefit, and it turned out that not merely was the test prognostic, but it was specifically predictive. A high score predicts that chemotherapy has a benefit. So it's really a fledgling early attempt to have a predictive test for chemotherapy sensitivity. And by the way, it does really impact how we think about tumors. Sometimes we can withhold treatment in cancers that 10 years ago we would have routinely given chemotherapy to. And conversely, there are situations where we historically might not have given chemotherapy, but a high score on that test warns us that there's a real chemotherapy benefit potentially there, and we might use that information. This is all somewhat novel for us, but it's a way forward in terms of individualizing care and predicting the benefits of therapy.
Yeah, what I'm going to say now is outside of what we're a whole bunch of friends, you know, is that when the Oncotype DS news kind of broke, somebody, a TV commentator wanted me to make a comment about it and kept saying, isn't it great that we can actually save people from chemotherapy now by doing this test and finding it doesn't work? And I kept saying, well, some people, you know, who would not have gotten chemotherapy should get chemotherapy by this test. Other people who would have gotten chemotherapy should not, so it really works both ways. And so he basically kicked me out of the room, didn't use my message, and hasn't spoken to me since, all right, because he wanted to have the big headline, saving people from the horrors of chemotherapy, rather than saving lives by giving chemotherapy where it's appropriate. So I'm just saying is be careful what you watch on TV, okay? Be careful with what you believe. Tan, you've done work indicating that some of these differences, I mean, we're talking about basically everybody's cancer is their own cancer. They're all different. And finding out what makes them different, you know, where they came from in you as an individual and how they're going to respond best to treatment is really what this is all about. It's getting back to the individual person. And you've made some discoveries about the character of the cancer being dependent on the kind of cell in the breast that the cancer came from. Do you want to say more about that? Because I think this is a very important topic.
Thank you for that segue to my work. And when you ask a scientist, what do you work on, they always want to tell you. So in addition to all these genetic markers that we are using to predict how cells, tumor cells will behave, a new frontier opened up, at least in my research, during the work that led to development of these culture nutrients that I spoke about. And we did a very simple experiment. We were able to grow two types of normal breast cells from one individual, and we inserted the exact same tumor genes into these two different cells and injected them in mice. And to our surprise, even though they came from the same person and they have the exact same genes, one cell gave rise to highly aggressive metastatic tumors, and the other cell had a hard time to even make a tumor. Now, this slightly complicates the genetic tests that we're wanting to apply to the clinic, because it means that a gene mutation, just by its mere presence, will not tell us exactly everything that we want to know. And you may despair about that, but at the same time, it opens up another kind of possibility, because remember the cell that had a hard time to even make a tumor, though it had very powerful tumorigenic genes? That means that you can suppress the effects of these genetic mutations somehow, even without correcting them. So we have to figure out what it is in those cells that suppress that tumor-driving activity of these genes. And we began with BCRF support about 5 years ago, try to figure out what that is. And I'll introduce you to a word. It's called epigenetics. Epi meaning on top of or above. And it turns out that in addition to the genes that we talk about all the time, there's a higher order of ordering of the genome. And I will liken this to, generally we talk about DNA as the book of life. Imagine a book where there's no punctuation marks, there's no gaps between sentences, no chapters. It's just from beginning to end a sequence of letters. That's what DNA is. What epigenetics does is put the punctuation marks, it puts the different chapters. Also, it tells different cells what parts of the book to read. So think about this. The diversity of cells we have in our body is astonishing. The nerve cells that are coming from your spine stretch all the way to your toes. So this would be like having a human being that's 150 feet tall and having a twin with the exact same genes being 6 feet tall. That's the kind of amazing diversity you can generate just reading the different parts of the book. You don't need a different book. So I will end this by saying that we found 2 proteins. They're called histone deacetylases, if you like terminology, or HDACs, that go and put different punctuation marks on the DNA, and that's one, not all, of the differences between these 2 cells that I speak about. And actually, I will announce this discovery on Wednesday at a meeting that's organized by a journal, scientific journal called Nature in Miami Beach. So we are making progress understanding how is it that the same genes do different things.